Okay. So starting with the anatomy of the extraocular muscles, we need to know first what are the extraocular muscles. Extraocular muscles are very unique muscles in the body, meaning that it is the most differentiated striated muscles all over the body. And what do we mean by differentiation? So if we have a muscle like back muscle, we have a limited or few nerves or nerve endings in relation to the muscle bulk. On the other hand, the nerves to muscle relation in the extraocular muscles is very, very high, because these muscles has to be or its function are very specific and it need to be very, very accurate. So they are highly differentiated, have a large amount of elastic and nerve fibers, and it consists of connective tissue fibers and the muscle fibers. When we will say in the embryology, or when we will discuss the embryology, we will see that there is a structure called mesenchyme that will develop during embryonic life. This structure is made of two main things. It's made of what's called the mesoderm and the neural crest cells. So if the extraocular muscles take each one of them or each part of the mesenchyme will give rise to a specific structure in the extraocular muscle. So the mesoderm will give rise to the muscle fibers, while the neural crest cells will give rise to the tendons and sheaths. So for the extraocular muscles, the gross anatomy is much more important than the microscopic anatomy, but we will need to just have a small ideas about the microscopic anatomy. So basically, the extraocular muscle is formed of muscle fibers and connective tissues. This connective tissue is in the form of sheath or tendon or nerve endings. So what are the main histological features of the muscle fibers, of extraocular muscle fibers, and what are the other histological features of connective tissue? Let's first try to identify what are the extraocular muscles. We have 4 recti muscles. So rectus is the Latin word for straight. So we have 4 straight muscles. We have the superior rectus, inferior rectus, medial rectus, and lateral rectus. Then, since we have 4 straight muscles, we have other obliques muscle. So these muscles are the superior oblique muscle here and the inferior oblique muscles. And we have another muscle which is considered also as an extraocular muscle, which is the levatopalpebral superiosus muscle. So as we said, let's discuss first the histological features of the extraocular muscle fibers. So the diameter of the fiber is about 9 to 30 microns, and each muscle fiber is surrounded by a sheath called the sarcolemma. So the sarcolemma here, as you can see here, this is the sheath that will enclose the muscle fiber. The muscle fiber contain numerous myofibrils that has a cytoplasm and and the multi nuclei located peripherally. So this is was asked before, that in the muscle fiber the nuclei are located peripherally in the muscle fiber. So again, we have the muscle fiber consists of multiple myofibrils and cellular organelles like mitochondria, like cytoplasm, and they are covered by the sarcolemma, and these the nuclei of these muscle fibers are located peripherally. The connective tissue we have, this is the muscle fiber, and this is the myofibril. You know that you will see that there is a connective tissue sheath covering the muscle fiber, which is called the endomysium. So the endomysium is a connective tissue sheath that surrounds the muscle fiber, while the perimysium is the muscle sheath that will group several muscle fibers. So connective tissue sheath that will contain several muscle fibers is called the perimysium, while the connective tissue sheath that will enclose the whole muscle is called the epimysium. So again, the endomysium will enclose the muscle fiber, single muscle fiber, while the perimysium will enclose several muscle fibers Finally, we have the epimysium, which is the connective tissue sheath that will enclose the whole muscle. The sheath of the muscle is different in structure from posterior to anterior. So from its origin until it is 2 centimeter, the sheath of the muscle will be thin and transparent, while from this point till the globe, it will be thick and opaque. The tendon itself are made of collagen, which are arranged parallel to each other, giving this glistening appearance of the muscle tendon. The tendon enter into the superficial sclera and then become indistinguishable from it. So they mingle with the layers of the sclera later on. And if you remember, we said that this is the one, or this is the thinnest location, or the thinnest part of the sclera is located at the insertion of recti muscle. Finally, we have the proprioceptive nerve endings. The proprioceptive nerve endings is the junction between the nerve fibers and the muscle fiber. This is called the proprioceptive nerve endings. And in the extraocular muscle, they take a very unique configuration that we will see now. So this is the bone, and this is the tendon, and this is the muscle. If we enlarge the junction between the nerve and the muscle fiber, then we will reach this configuration of what's called muscle spindle. So the muscle spindle are in the extraocular muscles smaller, and as it is corresponding to the small size of the fibers and small size of the muscle fibers in relation to other somatic muscles in the body. And what is characteristic about it, it is that it is enclosed within a torpedo-shaped fibrous capsule. So this is the fibrous capsule, like the shape of torpedo. And this torpedo-shaped fibrous capsule is enclosing intrafusal muscle fibers. So the muscle fibers within the capsule are called intrafusal fibers. So are there any muscle fibers outside the capsule? As you can see, yes. The answer is yes. So there are intrafusal fibers and extrafusal fibers. This fibrous capsule is about 2 or 3 layers, and the intrafusal fibers will take the configuration of 2 shapes. The first one, the muscle fiber enclosed within the nerve endings can be swollen like this. It is called the nuclear bag. Or sometimes the nerve endings make like a chain to the muscle. Then this is called the nuclear chain. So we have nuclear chain and we have the nuclear bag. Both of them are within the torpedo-shaped fibrous capsule. So what is the difference between the intrafusal fibers inside the fibrous capsule and the extrafusal fibers outside the capsule? That the intrafusal fibers have central nuclei, as you can see here, and smaller in diameter. So they are smaller in diameter than the extrafusal fibers. So again, we have here, this is the muscle fibers, this is extrafusal fibers, and this is intrafusal fibers. The intrafusal fibers are enclosed within a torpedo-shaped fibrous capsule made of 2 to 3 layers. These intrafusal fibers are either in the form of nuclear bag or in the form of nuclear chain. So this is the important histological features of the extraocular muscles. Let's now talk about the main bulk of the lecture, and the most important part, which is the gross anatomy. So I hope that you concentrate well, because it is sometimes very confusing. So here we go. We will divide them we will first discuss the recti muscles, then we will discuss the other muscles other than the recti, because the recti muscles share some common features, so it is better to group them together. Let's start first to talk about the origin. Where does the superior rectus, inferior rectus, medial rectus, and lateral rectus take origin from? As we said from the previous lecture, it takes origin from the common tendinous ring. So the superior rectus here will take origin from the upper part of the annulus of Zinn, while the inferior rectus will take part from the lower part of the annulus of Zinn. The medial rectus will take part from the medial part of the common tendinous ring, while the lateral part, lateral rectus, it is the only muscle that take origin by two heads. So there are two heads of the lateral rectus, here and here. So it takes origin from the lateral part of the common tendinous ring by two heads. So what are other specific features of the origin of extraocular muscles? That we have that the superior rectus and the medial rectus, both of them not only take origin from the common tendinous ring, but also from the sheath of the optic nerve. So the superior rectus here takes origin from sheath of the optic nerve, and the medial rectus there takes origin from the sheath of the optic nerve. And does this have any clinical significance or any clinical importance? The answer is yes. This is the reason behind why patients of optic neuritis will complain from pain with eye movement. This is because the optic nerve is inflamed and the superior and the medial rectus takes origin from this optic nerve sheath. Hence, they will suffer from pain with eye movements, which occur up to 90% of cases of optic neuritis. So again, here we have the medial rectus, lateral rectus, superior and inferior rectus takes origin from the common tendinous ring. So what will be the course of each one of them? The superior rectus will take origin from the common tendinous ring and pass forward and laterally. So the muscle is not straight with the axis of the globe, but it is directed lateral. As you can see here, this is the axis of the globe, and this is the direction of the superior rectus muscle. So it makes an angle between about 23 degrees between the muscle axis and the eye axis. And does this has any significance? The answer is yes. It has a huge significance in the action of the muscle, as we will see when we are discussing the action. So just remember for now that the muscle is passing forward and laterally, making an angle of 23 degrees between the superior rectus and the axis of the globe. And it lies beneath the levator palpebral superioris, as we said in the orbital lecture. So just below the roof of the orbit will be the vessels and the nerves. Then we have the levator palpebral superioris. Then the superior rectus will be lying below it. The inferior rectus will be the same thing like the superior rectus, meaning that it takes origin from the common tendinous ring, then it passes forward and laterally to insert into the globe. So this is the inferior rectus muscle, and we are seeing the globe from above. So here the inferior rectus is passing forward and laterally, again making an angle of 23 degrees with the axis of the globe. Medial rectus muscle will be run along the medial wall, and this is the most bulky muscle in the orbit. So the most thick muscle will be the medial rectus muscle, which will be running along the medial wall. And then we have the lateral rectus muscle. So the lateral rectus muscle takes origin by two heads, as we said. Then it will pass along the lateral wall of the globe, along with the lateral wall of the orbit, and they just pass above the insertion of this muscle. What is this muscle? This is the inferior oblique muscle. So the inferior oblique muscle, the course of the inferior oblique is horizontal, and it is inserted just below the inferior margin of the lateral rectus muscle. Now we come to the insertion. So you will have the anatomy text box will have a lot of numbers about the length of each muscle and the distance between each muscle and the other one, and a lot of figures. So do we need to memorize all these figures? The answer is no. But what you need to memorize is 4 main figures or 4 main distances. These are the distance between the insertion of the rectus muscle and the limbus. This is of extreme importance for the exam and for practice. So you need to know where is the muscle located. And this can be summarized by starting from the medial rectus. It will be 5.5 for the medial rectus, 6.5 for the inferior rectus, 6.9 for the lateral rectus, and 7.7 for the superior rectus. These are the main figures that you need to memorize and you were asked in the exam. Again, 5.5 starting always from the medial rectus and to below. 5.5, 6.5, 6.9, 7.7. If you repeat them a lot, you will be able to memorize it. And the inferior rectus below, it will make an expansion with the capsulopalpebral ligament or the ligament of Lockwood, as we mentioned in the previous lecture. So the capsulopalpebral fascia are fusing with the attachment of the inferior rectus muscle, or fusing with the insertion of the inferior rectus muscle. If we join the lines of insertions of all the recti muscle, then we will have what is called spiral of Tillow. So the spiral of Tillow, it is an imaginary line that joins the insertion of recti. The medial rectus will be the most close muscle to the limbus, while the superior rectus will be the most away muscle from the limbus. So again, why we study this, why this is important, because you need to know where is the muscle is located if you are going to do strabismus surgery. So for example, the medial rectus should be 5.5 in the normal virgin eye. If you are a strabismus surgeon and doing the muscle surgery, and you find that this muscle is 7 millimeter away from the limbus, so you will know that this patient has undergone previous surgery and this muscle was recessed. So you need to know what is the normal to know what is the abnormal. And the next important thing about knowing the insertion is that the sclera is thin. The thinnest location of the sclera is at this point. So if you are doing strabismus surgery or you are doing retinal detachment surgery and you need to suture the sclera here, you need to be very careful in order not to perforate the sclera, and we mentioned this before. And also these areas are more liable to trauma and more liable to rupture in blunt trauma to the eye. Now we will talk about the nerve supply. So what is the nerve supply of the recti muscles? The superior rectus, the superior rectus, the inferior rectus, and the medial rectus, all of them takes nerve supply from the oculomotor nerve. So the oculomotor nerve will enter the orbit from within the annulus of them and divide into superior branch and inferior branch. The superior branch will supply the levator palpebris superioris and the superior rectus, while the inferior branch will supply the inferior rectus and the medial rectus and will give branch to supply the inferior oblique. While the lateral rectus, it is this muscle will be supplied by another nerve, which is called the abducent nerve. So here is the lateral rectus, it is cut. And as you can see, there is a specific nerve, which is called the abducent nerve, which supply the muscle from its bulbar surface. So I hope that everything is clear to now. Because here, here where I need your concentration very much. As we are now will discuss the motility of the extraocular muscle. To understand the motility of extraocular muscle, we have to know that there are 3 axes of rotation of the globe. So we have the x-axis. This x-axis is a horizontal axis. If an eye is rotated around this axis, so the eye will be rotated upward and downward. So if we have, for example, we have a pipe or a pin that perforate the eye from the equator from side to side, and we need to rotate the globe, so the globe will be rotated above and downward. While there is another axis, it's called the z-axis. That axis, it is a vertical axis. So if we have a line or a pipe that perforating the globe in the z direction, and then the globe will rotate medially and laterally. So this will be the axis of rotation. And finally, we have a third axis, which is called the y-axis, which is an anteroposterior axis, meaning that it passes along the anteroposterior length of the eye. So if we have an axis here and the eye will rotate around this axis, it will rotate inward and outward, what's called intorsion and extorsion. And let's see this in more details in this video. So we have here we check the extraocular muscle movement. So movement of the eye in medially in this direction is called adduction. Movement of the eye laterally, this movement is called abduction. Then movement of the eye superiorly, then called elevation or supraduction. And the movement of the eye inferiorly will be called depression or infraduction. So these are the four rotations along the x and y axis. So what is how shall the eye rotate around the z axis, which is the anteroposterior? This will be inward rotation of the eye globe, which is called intorsion or encyclotorsion, or outside rotation of the globe, which is called excyclotorsion or extorsion. So let's repeat this again. We have medial movement, adduction. We have lateral movement, which is abduction. We have elevation of the globe, which is called elevation or supraduction. We have downward depression, which is called infraduction. Then the eye will rotate inward, which is called intorsion or encyclotorsion toward the nose, or rotate outside away from the nose, which is called extorsion or excycloduction. Okay. Let's now see what is the action of each rectus muscle based on the facts that we mentioned, based on the anatomical configuration of the muscle, and based on the three axes of the eye. So, which axis? This yellow line will be the central axis, and as a rule, if the axis of the muscle is coincidental with the axis of the eye, there will be synergistic action. So there will be increased action. But if the axis of the muscle is perpendicular on the axis of the globe, then both of them will antagonize each other. So there will be no action. Okay, so let's start first with the superior rectus. And we will assume that this is the medial, or the nose is here. So this is the medial, this is the adduction, and this is lateral, or this is abduction. Let's start first with the superior rectus. So here is the axis of the globe, and here is the axis of the muscle, as we said earlier, as it's passed forward and laterally. So what will be the main action of the superior rectus? The main action will be elevation. So by contraction of this muscle, the globe will rotate upward. So the muscle will shorten by contraction, causing elevation of the globe upward. So the eye here is rotated along the x-axis. So what happens if the eye is adducted or abducted? When the eye is abducted, look here, this is the primary position again. When the eye is abducted, the axis of the muscle will be coincidental with the axis of the eye. So there will be increased elevation. So the elevation will increase in abduction. So that again, the superior rectus will cause elevation that increase in abduction. But when the eye is rotated medially, the axis of the muscle will be perpendicular on the axis of the eye, so there will be no elevation. So again, the elevation increase in abduction, but absent in adduction. So if we are here using this x-axis, or the horizontal axis, the eye is rotated along the horizontal axis. Let's now have the adduction. The muscle itself, or the insertion of the muscle itself, act as an axis for the eye rotation, but this time this will be a vertical axis. So the eye will rotate into medially and laterally according to the contraction of the muscle, as the muscle insertion itself acts as an axis or pivot for rotation. So if the eye is adducted, there will be increase in the adduction. So the muscle will be increase the adduction as or the muscle will aid in adduction when the eye is adducted. So the main adductor of the eye will be the medial rectus, but the superior rectus will be able to increase the adduction when the eye is turned medially. Also, along the z-axis, the eye will go to intorsion. So the contraction of the superior rectus muscle will cause intorsion of the muscle, which increase again in adduction. So the superior rectus will cause rotation of the eyeball toward the nose, and this is called intorsion, and this intorsion increase in the adduction. As this is as in adduction, the eye is turned toward the nose. So again, to summarize the action of the extraocular muscle of the superior rectus, here we have the primary action, which is elevation along the horizontal axis. This elevation increase in abduction because muscle axis is coincidental with the eye axis, and absent in adduction because the axis of the muscle is perpendicular to the axis of the eye. There is a secondary action, which is adduction. So when the superior rectus contract, it can increase the adduction by the medial rectus. So it can lead the eye to be directed medially, as the muscle insertion itself acts as a pivot for rotation. Finally, we have the intorsion. So the contraction of superior rectus muscle will cause a rolling in of the eye toward the nose, toward the adduction, and since if the eye is adducted, this will lead to more intorsion toward the nose. Okay. What about the inferior rectus? So we here are looking to the inferior rectus, which has the same axis and the same angle with the axis of the globe as the superior rectus, but it is just from below. So what will be the action of the inferior rectus? The inferior rectus will cause depression. So if the muscle is contracted, it will cause depression of the eye due to a movement of the eye along the horizontal axis. This depression will increase in abduction again because the muscle axis will be coincidental with the axis of the eye, and it will be absent with adduction because the muscle axis is perpendicular to the eye axis, so they will antagonize each other. Again, the inferior rectus insertion acts as a pivot for rotation on the vertical axis. So if the inferior rectus is contracted, it will increase the adduction of the eye when turned medially, and the inferior rectus muscle will cause extorsion. So by contraction of the muscle, it will lead to rotation of the globe along the z-axis, which is this one from anteroposterior axis, causing rotation of the globe away from the nose, or extorsion or excyclotorsion. And this excyclotorsion will increase in adduction again. So again, the inferior rectus will the main action will be depression. As you can see here, there will be depression as a main action. This depression increase in abduction and absent in adduction. Also, it has a secondary action that will, by having the axis of the muscle is the insertion of the muscle, will be cause rotation of the globe into medial and lateral. So it will cause adduction of the eye. This adduction is more when the eye is turned medially, and it causes extorsion. So it will lead to outward movement of the eye globe away from the nose that increase in the adduction. Then we have two easy muscles, the medial rectus and the lateral rectus. So the medial rectus just as cause adduction, medial rotation, and the lateral rectus will cause abduction, lateral rotation. It's just as simple as this. So there will be no elevation or depression, no intorsion or extorsion. So we now finished the action of the erectile muscle. We will now discuss the other extraocular muscles, which are the remaining three, which are the levator palpebris superioris, superior oblique, and inferior oblique. So where do these muscles take origin from? The levator palpebris superioris takes an origin from the back of the roof. So here is the roof, and this is the back of the roof, and there is a periosteal covering of lesser wing of sphenoid, and here where the levator palpebris superioris takes origin from. So it is just in front of the optic canal. From the periosteal covering of the lesser wing of sphenoid, the superior oblique or the superior levator palpebris superioris takes origin. Then the origin, as you can see here, is fused with the origin of the superior rectus below and the superior oblique medially. So we here, just below the roof, we have the levator palpebris superioris, then just below it the superior rectus, and medial to them will be the superior oblique. All of them takes origin together, or the origin of them blends together. The superior oblique muscle again takes the same origin from the back of the roof, from the periosteal covering of the lesser wing of sphenoid, just anteromedial to the optic canal. The inferior oblique has its unique origin and course and insertion. So it is the only muscle that is that originate from in front of the equator. All other muscles are arising from behind the equator, except for the inferior oblique muscle. So it takes origin from the floor of the orbit, from the periosteum covering the maxilla, and then it runs horizontally, as you can see here, in front of the equator. So again, to have a closer look for these muscles, we have here the levator palpebris superioris muscle takes origin from the periosteal covering of the lesser wing of sphenoid. Anteromedial to the optic canal, we will have the superior oblique muscle here. And both of the levator palpebris superioris and the superior oblique muscle and the superior rectus muscle, all of them, the origin of all of them is fused together. While the inferior oblique muscle takes origin from the periosteal covering of the maxilla and run horizontally in front of the equator. Let's now see the course and the insertion of each muscle. The levator palpebris superioris muscle is unique for having a specific course and a specific insertion. So the levator palpebris superioris is moving just beneath or just below the orbital roof, where at area 1 centimeter behind the orbital septum, this levator palpebris muscle will be forming into aponeurosis. This is again asked in the exam, and asked about this number specifically, that the levator palpebris muscle is transformed into aponeurosis 1 centimeter behind the orbital septum. So what will happen when the levator palpebris is transformed into aponeurosis? So they will pass through the orbital septum. So it will be one of the structures that pierce the orbital septum. Then they will have 5 specific insertions that you need to memorize them by heart, because they are very important and very frequently asked in the exam. So what are these 5 insertions? The first insertion is into the skin of the eyelid. Into the skin of the eyelid, here is the skin of the eyelid, and the levator palpebris muscle aponeurosis will be inserting into this skin, making an important anatomical feature, which is called the crease or the superior palpebral furrow. So our upper lid crease is made by the insertion of the levator aponeurosis. Also, a part of from the levator will be inserted into the anterior surface of the tarsus. So here is the tarsus, and here is the levator aponeurosis, and it is inserted into the anterior surface of the tarsus. Also, the levator palpebris aponeurosis will extend along the tarsus and insert into the medial canthal tendon and the lateral canthal tendon. And these tendons will attach the both tarsi to the lateral and the medial orbital margins. So this is again one of the insertions. lateral orbital margin, lateral palpebral ligament or lateral canthal tendon, and medial canthal tendon or medial palpebral ligament. Also, it will insert into the superior fornix. So the superior fornix, it is the area between the palpebral conjunctiva and the bulbar conjunctiva. This is one of the insertions of levator palpebrae. And there is another muscle that arises from the undersurface of the levator palpebrae superioris to insert into the upper border of the tarsus. This muscle is called molar muscle or superior tarsal muscle, which is sympathetically innervated and responsible also for elevation of the eyelid. So again, to summarize the insertions, we have 5 insertions. The first one into the skin, causing the red crease. Then the second one into the upper surface or the anterior surface of the tarsus. Then the superior fornix. Then the medial and lateral palpebral ligament. And finally, the molar muscle, which is arising from the undersurface of the levator to insert into the upper border of the tarsus. Okay, let's now discuss the course and the insertion of the superior oblique muscle. So the superior oblique muscle, as we said, it takes origin from the periosteal covering of the lesser wing of sphenoid, and it passes in the corner between the medial wall and the roof of the orbit until it reaches a structure, fibrocartilaginous structure, present at the medial wall of the orbit or in the medial part of the roof of the orbit, which is called the trochlea. So the muscle enter into this trochlea and begin to reflect. So where is the muscle is formed of 2 main parts, the direct muscle part and the reflect tendinous part. So this tendon is starting again 1 centimeter but behind the trochlea. So remember that the tendon of the superior oblique starts 1 centimeter behind the trochlea, while the aponeurosis of levator is starting 1 centimeter behind the orbital septum. So what happens when this the superior oblique tendon pass through the trochlea? Then it will make a U-turn. So it will reflect from the trochlea to pass backward, downward, and laterally. And this passage will make an axis of about 55 degrees with the optical axis. So here is the optical axis, and the reflected tendinous part of the muscle will make an axis of 55 degrees. And it will pass backward, downward, and lateral. Then it will pierce the tenon capsule and it will insert the posterior upper lateral quadrant of the sclera, and this is again asked in the exam. So the superior oblique tendon is inserted into the superior upper lateral quadrant of the sclera. Other specific features regarding the superior oblique muscle that it is the longest extraocular muscle, and it is the thinnest, and it is the most rounded. So if you cut this muscle, you will find that the cut section is round or circular. The anterior end lies at the same meridian of the temporal end of the superior rectus muscle. So here is the anterior end, and this is the temporal axis of the superior rectus muscle. So again, here is the superior oblique muscle, arise from the periosteal covering of lesser wing of sphenoid, pass into the corner of the orbit between the medial wall and the roof, until 1 centimeter behind the trochlea. It is divided into tendon that will reflect to pass backward, downward, and laterally to insert into the upper posterior lateral quadrant of the sclera. Here, another section of the same muscle. So note that this muscle is the thinnest, the most slender, and the most long muscle of the extraocular muscles. For the inferior oblique, we said that it takes origin from the periosteal covering of the maxilla, and then it passes backward and lateral. So here it is moving backward and laterally to be inserted just below the inferior border of the lateral rectus muscle into the lower lateral quadrant of the sclera. So the superior oblique muscle is inserted into the upper lateral quadrant of the sclera, while the inferior oblique muscle is inserted into the inferior lower lateral quadrant of the sclera. and it is this muscle, it is the shortest muscle, or this muscle has the shortest tendon. Sometimes it is not present at all, and the insertion of this muscle is into close proximity from the optic nerve and from the macula. So severe or caution should be taken while excision of this muscle, not to cause any optic nerve injury or macular injury. Let's now talk about the nerve supply of these muscles. So the levator palpebral superiosus muscle will take origin from the superior division of the oculomotor nerve, as we mentioned earlier. And this nerve will pass around the medial rectus of the superior rectus muscle here, and then it will pass to the inferior surface of the levator muscle. So here is the levator, and the superior division of the oculomotor nerve will pass around the superior rectus to enter the levator from its undersurface. This is not the only nerve supply to the levator, because the levator has an important part which is called the molar muscle, and this molar muscle takes sympathetic innervation from the carotid plexus. So the molar muscle, or the superior tarsal muscle, it is a sympathetically innervated muscle. Then we have the trochlear nerve. The trochlear nerve, it is the nerve which is concerned with the levator, the superior oblique muscle. So here is the trochlear nerve. This nerve is specifically made for the superior oblique muscle. And finally, we have the inferior oblique, which takes origin from the inferior division of the oculomotor. So here we can see, again, this is another section. So this is the levator aponeurosis, and this is the superior division of the oculomotor, supplying both the superior rectus and the levator palpebral superiosus. And then we have, this is the inferior oblique muscle, which is supplied by a nerve from the inferior division of the oculomotor, which is called the nerve to inferior oblique nerve. Here is again the inferior nerve to the inferior oblique nerve, which is a branch from the levator aponeurosis. Sorry, a branch from the oculomotor nerve. Okay, let's see this nice video for the for better illustration of the ocular cranial nerves, specifically the oculomotor, abducent, and trochlear. So this is the oculomotor, divided into superior division and the inferior division. Superior division supplying superior rectus and levator, and the medial rectus, superior rectus and levator, while the inferior is supplying the inferior rectus and the inferior oblique and the medial rectus. Then we have the trochlear nerve, which is passed along the upper border or just below the roof to supply the superior oblique muscle. And finally, we have the abducent nerve, which is entered through the common tendinous ring to supply the lateral rectus muscle. Finally, let's discuss the action of these muscles. So we have the levator palpebral superiosus. This is, as it's obvious from its name, its main function is to elevate the eyelid. So by contraction of the levator palpebral superiosus, this will lead to elevation of the upper eyelid and the deepening of the superior fornix, and a deepening of the upper palpebral crease. Let's now discuss the other two somewhat difficult muscles for their action, which is the superior oblique and inferior oblique. And you will find that there is some similarity and some difference between the superior rectus and the inferior rectus. First of all, since the superior obliques and inferior obliques are obliques, their action will be against their name. So the superior will cause depression, while the inferior will cause elevation. So here we can see this is a superior oblique muscle inserting to the upper lateral posterior quadrant of the globe, and this is the muscle axis, as we mentioned earlier, and this muscle action is due to its reflection, or the reflected tendinous part. So if we have this muscle rotating along the horizontal axis, by contraction of this muscle, this will lead to depression of the globe again. Here are the medial, and here is the lateral. And if this muscle contracted, this will lead to depression of the globe. This depression will increase into in adduction. This is because the muscle axis will be the same as the optical axis or the axis of the globe. While on the abduction, there will be absent action. So the depression will not work into the abduction because the muscle axis will be perpendicular to the uh, optical axis. Then this muscle or the superior oblique muscle can cause abduction. The abduction is caused by the center of rotation will be in the trochlea. So when the trochlea act as a center of rotation, this will lead to lateral movement of the eye. It will increase abduction when the eye is in straight position. Finally, when the eye rotates along the z-axis, which is the anteroposterior axis, this will lead to intorsion. So this intorsion will cause so the superior oblique will cause intorsion or rolling in of the eyeball toward the nose, and this intorsion will increase in abduction. So by using the trochlea as a pivot for movement, then the muscle will cause abduction and the intorsion will increase in the abduction. The reverse will occur in the inferior oblique. So here is the inferior oblique passing horizontally and inserting into the posterior lower lateral quadrant of the globe. So this is the muscle axis, and this is the vertical axis or the globe axis. So what will happen if the inferior oblique muscle, which is lying below the globe, is contracted? This will lead to elevation. So the muscle will shorten, and this will lead. So here we are looking into the eye from below. So assume that you are now standing into the orbital floor and looking to the eye from the orbital floor. And so you will see that this is the muscle, the inferior oblique, originating from the maxilla till the posterior lateral lower quadrant of the globe. Then by contraction of this muscle, this will lead to elevation of the eye. So the inferior oblique is elevator. This elevation will increase in abduction again because the muscle axis will be the same like the optical axis, but it will not occur into the reverse. It will not occur into the abduction. So the muscle will not be acting into the abduction. Then by taking the insertion of the muscle as a center of rotation, if it's contracted, this will lead to abduction. So it will aid in the abduction when the eye in straight position, and it can cause excyclotorsion. So it can rotate the eye or rolling out of the eyeball away from the nose. And this excyclotorsion will increase into the abduction when combining the action of the muscle, the muscle action of rotation or excyclotortion in combination with its abducting action. So this is the action of the inferior oblique. So to summarize, we have the forerecti, the medial rectus will cause adduction, the lateral rectus will cause abduction, superior rectus will cause elevation and adduction and intorsion, inferior rectus will cause depression and adduction and extorsion. The superior oblique will cause depression, abduction, and intorsion, while the inferior oblique will cause elevation and abduction and extorsion. So let's see this video to summarize the actions of the extraocular muscles. So here the superior rectus will cause elevation and intorsion and adduction. Superior rectus will cause elevation, intorsion, and adduction. The medial rectus will cause only adduction. The inferior rectus the inferior rectus The inferior rectus will cause depression, excyclotorsion, and abduction. The superior oblique is the muscle of reading and descending downstairs. So if you are reading a book or descending downstairs, you are now using your superior oblique muscle because it causes depression, it causes intorsion, and abduction. The lateral rectus will cause just abduction. This is wrong. It's not adduction. This is abduction. And finally, the inferior oblique will cause elevation and extorsion and abduction. So this is the anatomy of the movement of the extraocular muscles. Finally, we reach to the final part of the lecture, which is the relations of the extraocular muscles. So what are the relations of the superior rectus? What is above superior rectus? As we said many times now, we have the orbital roof and levator palpebral superioris, and above the levator palpebral will be the frontal nerve, trochlear nerve, and supraorbital vessels, as you can see here, frontal, supratrochlear, and supraorbital. Below the superior rectus will be immediately the optic nerve and the ophthalmic artery and the superior oblique tendon. So the superior oblique tendon is reflected just below the superior rectus muscle. Laterally, we have the lacrimal nerve. So here the levator palpebral muscle and the supraciliar nerve, trochlear nerve, the optic nerve just below, and the ophthalmic artery again is below. The nasociliary nerve also is below the superior rectus muscle, and the superior oblique reflected part is below the superior rectus muscle, while the laterally will be the lacrimal artery and lacrimal nerve, and medially will be ophthalmic artery and nasociliary nerve. So there will be relations or the ophthalmic artery and the nasociliary nerves are medial and superior to the medial and inferior to the superior rectus. What are the relations of the inferior rectus? So what is above the inferior rectus? It will be the optic nerve, the inferior division of the oculomotor nerve, and the inferior ophthalmic vein. So what is inferior to the inferior rectus? There will be an orbital floor, the infraorbital vessels and nerves, and the nerve to inferior oblique. What is the lateral? It will be again the nerve to the inferior oblique. And what will be these are the relations of the orbital floor. Now, what are the relations of the medial rectus? Here is the medial rectus. So above it will be the superior oblique muscle, as we can see. And in between the medial rectus and the superior oblique will be the ophthalmic artery, the ethmoidal vessels and nerves, and the supratrochlear nerve. So here is the superior oblique muscle, and here is the ophthalmic artery in between the two muscles. And inferior to the medial rectus will be the orbital pad of fat. Laterally to the medial rectus will be again the fat or the orbital fat, and medially will be the orbital plate of ethmoid, as you can see here, separating it from the ethmoidal sinus. Here we can see that the medial relations above the medial rectus will be the superior oblique, and in between the superior oblique and the medial rectus will be the supraorbital vessels and nerves. Sorry, the ethmoidal nerves and arteries and the infratrochlear nerves. Then we have medially will be ethmoidal air cells, as you can see here. Then the lateral rectus. So the lateral rectus, we will not mention anything new. So the lateral rectus relations is at the apex, as we said. The lateral rectus originate by two heads, and these two heads enclosing the annulus of them. So there are structures passing between the two heads of lateral rectus are the same structures that pass within the annulus of them. and there are structures above the lateral rectus and structures below lateral rectus. So as we mentioned before, the structures within the common tendinous ring will be the superior division of the oculomotor and inferior division of the oculomotor, nasociliary nerve and the abducent nerve, and the inferior ophthalmic vein. So the inferior ophthalmic vein was below, then become inside the two heads of lateral rectus. Then there are structures passing above. There will be the lacrimal, the frontal, the trochlear nerve, the recurrent meningeal artery, and the superior ophthalmic vein. So this is just a repetition of what we have said in the orbit lecture. But just the new thing here that you just need to know that the muscle cone or the common tendinous ring is enclosed within the or the lateral or the upper and lower heads of the lateral rectus are enclosing the common tendinous ring or annulus of them. So what are the relations of the lateral rectus? Above the lateral rectus immediately will be the lacrimal artery and lacrimal nerve that supply the lacrimal gland. And below the lateral rectus will be the orbital floor and the inferior oblique tendon. Here is the lacrimal artery and lacrimal nerve, as you can see. After we remove the lateral rectus, they pass directly into the lacrimal gland. Inferior to the lateral rectus will be the orbital floor, as you can see, and the inferior oblique tendon, as we just mentioned, that the inferior oblique tendon inserts just below the lateral rectus. Lateral relations are the posterior, the periosteum, and in the middle there will be orbital fat, and the anterior will be the lacrimal gland, as you can see here. So posterior will be the periosteum, in the middle will be the orbital fat, and anteriorly will be the lacrimal gland. And finally, medially, there will be some important structures between the lateral rectus and the optic nerve. So there will be the abducent nerve and the oculomotor nerve, as you can see here, are located between the lateral rectus and the optic nerve. We have the ciliary ganglion and the ophthalmic artery and the nasociliary nerve, and between the lateral rectus and the inferior rectus will be the nerve to inferior oblique. Here, the nerve to inferior oblique will be between the lateral rectus, which is cut here, and between it and the inferior rectus. For the levator palpebral superiosis, there will be nothing new. So what will be above the levator palpebral superiosis? It is the inferior relations to the orbit. So it will be the frontal nerve, the trochlear nerve, and the supraorbital vessels. Frontal nerve, the trochlear nerve, and the supraorbital vessels. Just below the levator, we said it will be the superior rectus, below the levator palpebral superiosis, and there will be the optic nerve and the globe. What is in front of the aponeurosis? Here is the aponeurosis. In front of the aponeurosis, immediately what is called the pre-aponeurotic pad of fat. So there will be retroseptal fat here, and there will be the orbital septum. Here is the aponeurosis, and in front of it will be the retroseptal fat or the pre-aponeurotic pad of fat, and the orbital septum and the orbicularis oculi muscle. So here is the retroseptal fat, here is the orbital septum, and here is the orbicularis oculi muscle. While behind the aponeurosis will be other relations. What is located behind the aponeurosis? There will be what's called the peripheral arterial arcades. So here, the branches from the medial and lateral palpebral arteries will make a peripheral arcades and what's called tarsal arcade. The peripheral arcade lies behind the aponeurosis. And here is the levator aponeurosis. And there will be the palpebral portion of lacrimal gland is located behind the aponeurosis. Then we have the relations of the superior oblique. What is above the superior oblique? There will be the roof. So the superior oblique is running between the medial wall and the roof. Inferior to the superior oblique, there will be ophthalmic artery and its branches, and the nasociliary nerve and its branches, and both ophthalmic artery and nasociliary nerves are closely related to each other, as you can see here. Lateral, there will be the supratrochlear nerve, as you can see here. And finally, the inferior oblique. So the inferior oblique muscle here, what is facing the upper surface? First will be the orbital fat here, then the inferior rectus muscle, and then the globe. So what is above the inferior oblique? The fat, the inferior rectus muscle, the globe. And what is below the inferior oblique muscle will be the fat, then the orbital floor, and below it the maxillary sinus. And it is covered by the lateral rectus, as we mentioned, and the tenon capsule, as you can see here. So the insertion of the inferior oblique is enclosed, just below the inferior margin of the lateral rectus. So in order to make some general rules to make our life easier and to facilitate the memorizing of the action of extraocular muscles, we have some general rules. So all recti are adductors. So we are talking, of course, about the superior and the inferior recti. So the superior and the inferior recti are adductors, while obliques are abductors. So the superior oblique and the inferior obliques are abductors. The superior muscles are intortors. So the superior rectus and the superior oblique cause intorsion, while the inferior muscles are extortors, meaning that the inferior rectus and the inferior oblique are extortors. Finally, we have just to mention about some hints about the general consideration about the of extraocular muscles. So the blood supply of extraocular muscle is coming from the medial muscular branch of the ophthalmic artery, or sometimes it arises from the lacrimal artery to supply inferior rectus, inferior oblique, and the medial rectus, while the infraorbital artery will supply the inferior oblique muscle. As we said that all extraocular muscles are supplied by the oculomotor nerve except for the lateral rectus, which is supplied by the abducent, and the superior oblique, which is supplied by the trochlear. All recti muscles insert in front of equator, while obliques insert behind the equator. Remember, we are talking about the insertion. But if we are talking about the origin, then all muscles will take origin behind the equator, except for the inferior oblique, which will take origin from in front of the equator. All obliques are below the recti, so the superior rectus is superior oblique is below the superior rectus, and the inferior oblique is below the inferior rectus. Medial rectus is the most bulky muscle, and it is the most strong and the most large, while the lateral rectus is the longest. If all muscles contract, they will cause a retraction of the globe, while if the two obliques only contract, they will cause protrusion. If there is a lesion affecting the levator-palpebral superiosis, this will lead to leading to ptosis. It will lead to central ptosis, because this muscle will supply the eyelid, or responsible for elevation of the eyelid. But if there is lesion only to the molar muscle, which is a sympathetically innervated muscle arising from the superior levator palpebrae, this will lead to only mild ptosis, because the action of the molar muscle will lead to just elevation of the eyelid by 2 millimeters. So it is a sympathetically innervated muscle that will cause mild elevation of the upper eyelid. So if it is damaged, this will lead to mild ptosis, and this is what occur in Horner syndrome. So this is the end of the extraocular muscle lecture. I will leave you now with this nice video for the anatomy of the extraocular muscle. I hope that you enjoy it, and you are free to ask any question after the end of lecture.
This is Peter from Anatomy Zone, and in this tutorial we'll take a look at the extraocular muscles. This video is a collaboration between Anatomy Zone and teachmeanatomy.info. Check out the links in the video description below for some useful articles to accompany this video tutorial. The extraocular muscles are located within the orbit, but are extrinsic and separate from the eyeball itself. They act to control the movements of the eyeball and the superior eyelid. There are 7 extraocular muscles: the levator palpebrae superioris, the superior rectus, inferior rectus, medial rectus, lateral rectus, inferior oblique, and superior oblique. Functionally, they can be divided into 2 groups. The first group is responsible for eye movement, the recti and oblique muscles, and the second group is responsible for superior eyelid movement, that is the levator palpebrae superioris. Before we take a look at these muscles, let's review the different movements of the eyeball. We will use the pupil as the point of reference for movement. The pupil can be moved up and down, which is known as elevation and depression. Abduction and adduction of the eyeball causes the pupil to be moved laterally and medially, respectively. The eyeball also has torsional movements, which bring the eyeball towards the nose, intorsion, and away from the nose, extorsion. These movements are also referred to as internal and external rotation. Let's take a look now at the levator palpebrae superioris. This long name is the descriptive Latin name which literally translates as the elevator of the upper eyelid. The levator palpebrae superioris is the only muscle involved in raising the superior eyelid. The eyelids contain a structure called the tarsus, a superior tarsus in the upper eyelid and an inferior tarsus in the lower eyelid, which provides significant support for the structure of the eyelids. A collection of smooth muscle fibers attaches from the levator palpebrae superioris to attach on the superior aspect of the superior tarsus. This collection of muscles is known as the superior tarsal muscle and is innervated by the sympathetic nervous system. This muscle originates from the lesser wing of the sphenoid bone, immediately above the optic foramen. It attaches to the superior tarsal plate of the upper eyelid, which is a thick plate of connective tissue. The action of this muscle, as the name suggests, is to elevate the upper eyelid. It is innervated by the oculomotor nerve, cranial nerve number 3. The superior tarsal muscle, located within the levator palpebrae superioris, is innervated by the sympathetic nervous system. Let's take a look now at the muscles involved in eye movement. There are 6 muscles involved in the control of the eyeball itself. They can be divided into 2 groups. You've got the 4 recti muscles and the 2 oblique muscles. Let's start first with the recti muscles. There are 4 recti muscles: the superior rectus, inferior rectus, medial rectus, and lateral rectus. These muscles characteristically originate from the common tendinous ring, also known as the annulus of Zinn. This is a ring of fibrous tissue which surrounds the optic canal at the back of the orbit. From their origin, the muscles pass anteriorly to attach to the sclera of the eyeball. The name recti is derived from the Latin word, which means straight. This represents the fact that the recti muscles have a direct path from origin to attachment. This is in contrast with the oblique eye muscles, which have an angular approach to the eyeball. The superior rectus muscle originates from the superior part of the common tendinous ring and attaches to the superior and anterior aspect of the sclera. The main action of this muscle is elevation, and it also contributes to adduction and medial rotation of the eyeball. It is innervated by the 3rd cranial nerve, the oculomotor nerve. The inferior rectus muscle originates from the inferior part of the common tendinous ring, and it inserts onto the inferior and anterior aspect of the sclera. Its main movement is depression, but it also contributes to adduction and lateral rotation of the eyeball. It is innervated by the oculomotor nerve, cranial nerve 3. The medial rectus muscle originates from the medial part of the common tendinous ring and inserts onto the anteromedial aspect of the sclera. It acts to adduct the eyeball. This muscle is also innervated by the oculomotor nerve, cranial nerve number 3. The lateral rectus muscle originates from the lateral part of the common tendinous ring and attaches to the anterolateral aspect of the sclera. As you may guess by the insertion point of this muscle, it acts to abduct the eyeball. This muscle is innervated by the abducens nerve, cranial nerve 6. You can see now why the abducens nerve gets its name, because it is responsible for the abduction of the eyeball via innervation of the lateral rectus muscle. Let's take a look now at the oblique muscles. There are two oblique muscles, the superior and inferior obliques. Unlike the recti group of muscles, they do not originate from the common tendinous ring. From their origin, the oblique muscles take an angular approach to the eyeball, in contrast to the straight approach of the recti muscles. They attach to the posterior surface of the sclera. The superior oblique originates from the body of the sphenoid bone. Its tendon passes through a fibrocartilaginous pulley known as the trochlea, which is attached to the trochlear fovea of the frontal bone. From here, the superior oblique muscle then attaches to the sclera of the eye, posterior to the superior rectus muscle. It acts to depress, abduct, and medially rotate the eyeball. This muscle is innervated by the trochlear nerve, cranial nerve number 4. The inferior oblique muscle originates from the medial side of the orbital floor. It attaches to the sclera of the eye, posterior to the lateral rectus muscle. Its action is to elevate, abduct, and laterally rotate the eyeball, and is innervated by the third cranial nerve, the oculomotor nerve. So all the extraocular muscles are innervated by the oculomotor nerve, except for the lateral rectus and the superior oblique, which are innervated by the abducens nerve and the trochlear nerve, respectively. It's important to note that whilst you can describe the actions of each muscle in terms of its specific movements of the eyeball, that all the extraocular muscles work in conjunction with one another to produce coordinated movement of the eyeball. For instance, in the vertical plane, to produce elevation and depression, the superior rectus muscle and the inferior oblique muscles work together in a coordinated manner to produce elevation of the eyeball. When the eyeball is in the neutral position looking straight ahead, both these muscles will contract to produce elevation. When the eye is held in an abducted position, the superior rectus muscle is mainly responsible for elevation, whereas in the adducted position, the inferior oblique is mainly responsible for elevation, and vice versa with regard to depression of the eyeball and coordination of the inferior rectus muscle and the superior oblique. That is, in the abducted position, the superior and inferior rectus muscles are responsible for elevation and depression, whereas in the adducted position, the superior and inferior oblique muscles are responsible for elevation and depression. Also, as you can see, there are several muscles which produce the same movement. The main abductor of the eyeball is the lateral rectus muscle, but this movement will also be assisted by the superior and inferior oblique muscles. So that's the anatomy of the extraocular muscles. If you have found this video useful, please click on the like button below and subscribe to Anatomy Zone for more tutorials. Thank you for watching.
Thank you for attending the lecture. I hope that you enjoyed it. Please, if you have any question, please let me know.